and welcome to another Pipe at Pearl. Today's Pearl, we're going to look at the chest examination. The chest examination pretty much happens during all general consultations and physicals, and it also has links with your HEENT consultations and examination, and obviously anything associated with cough or dyspnea, difficulty breathing, trauma. So it's a very common examination to go through. The goal of today is to look at the tools of the trade, go through the 4 principles of chest examination and weigh up which ones are more important than others, and also to give you tips and tricks in order to optimize your examination to get the best data you can, leading to the best care for the patient. So to start off, we'll just look at the tool of choice, which is the stethoscope. So when you start your career, you have the big decision in choosing a stethoscope. Now, there are a lot out there, and they range in price, they range in specialty. So you really need to have a look at what you're going to buy for your career. And most of the times, you will end up purchasing more than one stethoscope within your career. I've forgotten how many stethoscopes I've actually gone through in my career, but I have 2 main ones now that I've finally invested in, and they have served me very, very well. So we'll talk about those in a little bit. It really is in your best interest to invest in a high quality stethoscope. Now, that doesn't mean the most expensive stethoscope, but a high quality one. If you're picking one up from a local servo for 20 bucks, then you're probably not doing yourself any favors. Litmus is very good. They've got a great reputation, but they're not the only ones on the markets that have this good reputation. So just shop around and have a think. The stethoscopes that sell themselves as 2 tubes, so double tubes, 2 lumen, they're not the best. Even though they may be marketed as the best, they actually can generate friction between those tubes, and you can get some false readings as a result of that. So single tube is better based on the data, and a shorter stethoscope is better as well. If you can get a stethoscope that is thick and relatively stiff, then you're obviously going to get better sounds because there's less resistance. You'll often find stethoscopes get marketed as extra length, so then you can wear it over your neck and drape it over your shoulders and look really cool like they do in the TV shows. Okay? But that's not the goal of stethoscopes. So sometimes it's better to go shorter and thicker as opposed to the long, thin, and comfortable stethoscopes. When you're looking at the earpiece, you need to trial the earpieces out. Everybody's ears are different, and stethoscopes come with a series of different earpieces. So buy one with the options and test them out. They should fit snugly, so they're secure in your head, basically covering the external area of the auditory canal behind the tragus, and shouldn't be painful. So if you have a stethoscope and the earpieces that come with the stethoscope are no good for your ears, then you can go into the shops or go online and you can purchase additional earpieces to suit. When you are looking at the chest piece is the device at the end of the stethoscope that does all the listening. You need to decide what you need. You do have options that you can screw off and on in order to change the size of them to go from adult to children. These ones tend to create resistance as well as some friction points too. So just play those by ear. The 2 main chest pieces you can get is the diaphragm and the bell. The bell is designed for listening to low frequencies like the abdomen, and the diaphragm is best for listening to high frequencies like you'll find on the lungs. So if you have one that has both, then that's great. If you don't need the bell and you're doing it for different reasons, and you can get those stethoscopes that just have the diaphragm. There's also some these days that have the duality of bell and diaphragm based on the pressure you push down on the end of the chest piece. And there's always the option to go electronic, which you may decide to do as you get older and your hearing gets a little bit worse. Bottom line is, consider your job. Consider the environments you're going to be working in, and consider the demographic you're going to be working in, and the type of examinations you are capable of when making the decision on what stethoscopes to buy. So not selling any particular stethoscope, I'll just go through the 2 stethoscopes that I use just to give a little bit of insight into my thinking. So I didn't start my career with these stethoscopes, but as I moved on, got a little bit more mature, I ended up getting these. So because my work is diverse, I have 2 different types of stethoscopes. Now granted, the one on the left, its treatment team and clinics, will suffice for field work. It's just a little bit too expensive and fancy for me to want to sacrifice to the hazards that you find in the field. So I have 2. So the one I use in treatment teams, hospitals, clinics, that sort of thing, is an electronic one. It has the ability to swap between diaphragm and bell with a push of the button, and I can also amplify the sound that I'm hearing just by turning up the volume. It doesn't have recording abilities, however you can get those ones, and it is quite expensive. It's not ridiculously expensive that you can get, because I'm not a cardiologist, so I don't need the excessively high-end ones, but because I'm getting older, I wanted to get a good stethoscope, fits well, and has the options for me to manipulate the volume based on what I'm listening to. So that's the one I use. The one for field work is short, fat, just has a diaphragm. It's smaller, so it's quite lightweight. It doesn't have the length of the tube because I'll never wear it around my neck. And it also means there's less resistance in those louder environments. So it's a little bit more crude, but still high quality. And I can use it for all examinations when I just need to really find the big things and find out the filtering things before I move patients on to the better clinics. Okay, so they're the 2 that I carry, one that's more robust and suited for the field work, and one that's a little bit fancy, a little bit more variety for me to work in the different environments that I choose to work in. Okay, let's move on with the actual examination aspect. So all examinations you do, generally when you're learning them, we've broken down into 4 key principles of inspection, palpation, percussion, and auscultation. This one will have no difference, but obviously some vary greater than others. When we're dealing with inspection, inspection starts as soon as the patient walks in, or as soon as you rock up to the patient. During the inspection, you should pay particular attention to the person's breathing, as in the way they are breathing. Don't tell the patient you're doing this, but look at if they're breathing thoracic abdominal breathing, look for your costal markers, look for the use of accessory muscles like your sternocleidomastoid or intercostal muscles themselves. If you do notice that someone's using accessory muscles, it can point to an increase in effort needed based on different pathologies. So it's a good clue. Look at the way the patient has positioned themselves. Look for any dysfunction in the way they're sitting. The old tripod position is a classic one. And also look to see if they're breathing through something known as pursed lips. That's where they need to really focus down on pressure in order to exhale. It's quite common in emphysema. As you're talking to the patient and getting your subjective data, listen to the way they talk. Obviously, talking and sound and breathing control comes with the moving of air over the vocal cords. So if the person has to take long pauses, is unable to finish sentences, is only speaking in short bursts of words, then this is usually indicative of loss of breathing control, difficulty, painful breathing, or some sort of restriction or obstruction that they find in the lungs. So all this happens before you actually have a look at the skin and the chest and everything like that. The problem with inspection in chest examination is as soon as you tell somebody that you are looking at their breathing or you're taking a breathing rate or anything like that, their mind takes over, and that autonomic control based on the body needs is taken over, and the person thinks about their breathing too much, controls their breathing too much, and you get false breathings all the time. Now, normally a breathing pattern for an adult is 12 per minute. Even though statistically 20 is the most common number written down on charts and in hospitals, 12 is actually the number that is more common. And the old rest rate is the most fudged and lied about or out of any of the other vital signs that you can do. The old virtuous breathing rate is written down very, very, very commonly. So try not to fall into that very common clinical trap. Palpation is important when it's important. So when you're dealing with trauma and that sort of thing, obviously palpation of the chest is a very good thing to do, especially when you're looking for holes or you're looking for fractured ribs, you're looking for problems like that. A palpation of the chest is vital. When you're doing it for a pathological or more of a examination in primary healthcare setting, it doesn't have as much bearing. You can feel for something known as tactile firmitus, which basically means you just put your hand on the back of somebody's back in between their scapula and get them to say the word 99. If you have hyperresonance that you feel, so you actually feel an increase in this density or vibration, then it can mean that they have some sort of increased density within their lungs. And if you have an increase, it can actually mean that there's air in between the pleural space. So it's indicative of an early pneumothorax. Now, this can be a sign, but it really is based on you doing this to a whole bunch of people so that you know what normal vibration and density feel like before you can really test the abnormal. So it's really better to be picked up during auscultation. Speaking of which, auscultation is the most important aspect in the investigations when you're dealing with the lungs. Okay, so you use the stethoscope and you use the diaphragm of the stethoscope and you do the anterior and then you do the posterior. A few points to note, obviously, with the anterior, we're running down the sides of where the bronchi will be because we're listening for bronchial sounds. And then you move out to the exterior and the sides in order to listen to those vascular sounds as well. Okay, so always start at the top of the chest and then test the one side and then compare it to the other. If somebody has a complaint on a particular side of their chest, you always start with the good side and then compare it to the bad in order to note what's normal and then what's abnormal. And you move all the way down. Don't be surprised if you hear heart sounds as well, especially in the anterior wall. Just take note of those. We're not really going to talk about heart sounds today because the focus is on the lungs. Most of the recommendations and most of the chest textbooks and most of the training that you'll do is all about a chest auscultation on a male. Now, for obvious reasons, when you're doing an auscultation on a female, you have a couple of variables in the way that make auscultation difficult, embarrassing for the patient and the examiner alike. They actually did quite a large study on male examiners, and they found a marked decrease in the quality of the chest examination when that physician was treating a female. So obviously breasts are going to get in the way, and you don't want to strip the patient down completely when you don't have to. So the best thing you can do is really move more medially when you're dealing with the 3s and 4s. So you can get in between around the sternum in order to get those sounds. And when you're doing the 5 and 6 on the picture, you move around to the lateral aspects. If they're wearing a bra, sports bra, anything like that, some studies say you can go over the top, but it really degrades the quality in what you're hearing. So it's best just to place the stethoscope underneath momentarily in order to get a listen to. Big thing is when you're doing a chest examination on a girl and you're a boy or even a girl, you need to respect the patient obviously and really focus more on what you can hear from the back as opposed to what you can hear on the front and work around the boobs. When we move to the posterior, you can really hear a lot more, and most of the chest examination is really done from the back. The front is mostly there to listen for those lobular pneumonias, those really focused areas of problems, as opposed to a systemic resistance like wheezes and things like that. All that is picked up from the back nice and easily. So you follow the same method on the back. We start on one side, move systematically over the side, focusing mostly on the bronchial and the bronchial vesicular sounds, which is your 1s through to 5s. And then you move laterally on either side to 6s and 7s in order to really listen to those vesicular sounds and to get an indication of what's happening around that pleural space. A few tips you can do in order to make it a lot easier for you is, when you're doing the posterior aspect, get the patient to cross their arms over, therefore opening up their scapula, allowing less area between them and the actual lungs themselves, and get them to breathe through an open mouth. If they breathe through a closed mouth or through their nose, you can actually get the air passing through the oral cavity or the nasal cavity, and you can hear that, as opposed to what is passing over the bronchi and the bronchioles. So always get the patient to breathe through an open mouth, and when you're listening to the back, get them to cross their arms over. Now, what we are listening for is obviously, hopefully, we're going to hear normal sounds. Okay, so normal sounds are what's known as your bronchial sounds and your vesicular sounds. Now, vesicular sounds is a little bit funny because we've known for a very, 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 very long time that the sounds that are made are not actually from the vesicles themselves. So they're nothing to do with the air in the alveoli or the vesicles at all. They've actually got to do with the air passing over the very small tubes of the bronchioles. But we still stick with the term vesicular sounds. But whatever, I'm not going to change that. So we listen to bronchi, they're going to be quite high, high pitched, quite loud, and then the vesicles will be normal, but they'll be a much lower pitch. So we'll just go through an example of what is a normal bronchial sound and a normal vesical sound before we move on looking at the abnormal. Now that we have an idea of what the normal sounds like, we'll start looking at the abnormal sounds. And the first class we'll look at is the wheeze. So a classic wheeze is known as a high-pitch continuous sound that is suggestive of your asthmas, COPD, airway obstruction, or even a mucus plug. It is caused by the air flowing from the smaller areas of bronchioles into an area that has been resisted. So therefore it's much smaller, sometimes slit-like, if you imagine a whistle, and as you blow through a whistle, you get this high-pitched musical sort of sound. Now, because the resistance works both ways, you can actually get an inspiratory and an expiratory wheeze. So it's what's known as continuous. A lot of the other things you'll find in the lungs that isn't a wheeze isn't continuous. Now, wheeze can be over the entire lungs, or it can be in a very local area. When it is high-pitched, it is known as a wheeze. If you have a low-pitched continuous musical sound, then sometimes that is known as a rhonchi. Now, I want you all to get into the habit of never using the term rhonchi again. The reason for that is, for some reason, it has been conflated and mixed up. So a rhonchi is known as a wheeze, and it's also known as a restriction, more of a gargling sound as well. So you're best to use the term wheeze, low pitch, high pitch, wherever you find it, and ignore the fact that rhonchi ever existed, because it creates confusion in your notes and confusion during your handover. So we'll just have a listen to a high pitch wheeze versus a low pitch wheeze. I want you to listen for that continuous musical pitch that you'll find, and just imagine the air passing through a smaller lumen like a whistle, creating the sound that you'll hear. Sticking with the wheezes, another type of wheeze you can hear is what's known as a stridor. So a stridor is a loud, high-pitched musical sound that's produced by an upper respiratory tract obstruction, as opposed to a wheeze, high-pitched, low-pitched wheeze, which is more of your lower respiratory tract obstruction. It's indicated that the extrathoracic upper airway is somehow destruction. So we're looking at the supraglottic lesions, looking at something to do with the laryngeal or the vocal cords, and it's heard on inspiration mostly. If it occurs on expiration, it is more associated with the interthoracic problems themselves. Now, it can occur in both phases if you have a problem in the bronchs themselves, and it's a fixed problem like stenosis. Okay, so the main characteristics of a stridor is it's mostly heard on inspiration, can be heard on expiration, and if it's heard on both, it is a fixed obstruction of the upper airway, like your stenosis. Okay, so a stridor is more of your bronchial sounds that you'll hear in the medial aspects of your auscultation, as opposed to the lateral aspects, which is your general wheezes. So we'll have a listen to the characteristics of a stridor. Moving away from our wheezes, we'll have a look at another characteristics of sounds that you can hear, which is known as a crackle. Now, the crackle is a popping sound that is generated by air passing through the accumulated secretions within the large and the medium-sized airway. So the creation of the bubbly sound, which is a non-musical, discontinuous, so it only happens every now and then, is actually a result of the airways momentarily popping open due to pressure and then slapping closed. Okay, so as they pop open and then slap closed, when the pressure changes in these medium to low areas, you'll get this characteristics of a popping or a crackle sound, which is also known as rales. Now, it can be fine or coarse. You can also denote things like if it's early, which means early during the inspiration only. If it's late, and that's where you get the difference between the mid to lower airway. But then you also can get something known as pan crackles or pan inspiration, which means it is all over, right from the start, right through to the end. And that denotes quite a large consolidation of mucus across all the airways. And it's really difficult for the patient to breathe. So we'll have an example of what is fine crackles. It can be quite difficult to listen to, and you'll find these in the lateral aspects with a good stethoscope. And then you'll have coarse crackles, which is more medially in those medium bronchiolis areas. Okay, the last abnormal sounds that we'll listen to is known as a gurgle. Now, unfortunately, I couldn't find an audio for a gurgle, so I'll just have to do my best to explain what I'm actually talking about. So a gurgle occurs when air goes over water. So if you imagine that you have a straw and you're sort of gently blowing bubbles into a glass of water and you're hearing that sound, that's basically what it sounds like. Not exactly, but it's created by airflow going over and then creating this bubbling effect in fluid that has filled the lungs. Now, obviously, it can be quite loud when you're dealing with quite significant pulmonary edema, but it can also be quite subtle when it's down into the alveoli itself. But it does sound like the bubbling effect or a bong, if you have that sort of history, is what you'll hear in the base of the people's lungs. Now, this is actually more classically known as your rhonchi or your rhonchus. But again, it's best not to use that terminology. It's best to refer to it as gurgling itself. Now, pleural rub is not classified as gurgling. It sort of sits on the outskirts of what we're talking about. But because it's going to link more closely to our percussion when we get to it, it's best to note the sort of thing that you're going to hear in this space. So when you hear a pleural rub, it occurs due to an inflamed pleural surface rubbing together during breathing. Now, it's very difficult to differentiate from fine crackles, believe it or not. Okay, it actually sounds like fine crackles, but the real difference is it actually sounds like if you were to get your stethoscope and gently rub it over the top of cotton. That's what it sounds like when the person's breathing. So don't be discouraged if you pick it up as fine crackles as opposed to a pleural rub, because there's some other tests that we can go into in order to pinpoint down what the pleural rub is as opposed to those characteristics of a crackle. So we'll just have a listen to a pleural rub. Okay, because that was a bit to go through, we'll just summarize the three main abnormalities that you can get within the lungs. So even though you may have remembered learning a whole list of things, they can really be pinpointed down to three different characteristics. And if you focus on these three, then you really can't go wrong. So a crackle is that characteristics of the air popping as the smaller or middle airways open up and slap close. So you'll hear this popping, crackling sort of sound within the airways themselves. So it does sound a little bit like your pleural rub, as I've mentioned, but if you listen in different areas and you still hear the crackling, then you can move more towards the pathologies of a crackle as opposed to a pleural rub. Inflammation of the pleural space tends to be found in a particular area as opposed to all over, which is more associated with your crackles because it's caused by your bronchial exodus, your bronchitis, pneumonia, things like that. Okay, so that's what we listen to. The other one is the wheeze. As denoted by the picture, it's the smaller airways really pushing and forcefully trying to get that air out during expiration, mostly, that you'll hear the whistling because the actual lumen and the diameter of the airway has been reduced. So this is your asthma, COPD, and other airway obstructions that you'll hear. If you hear it in the upper airway, it's stridor. If you hear it in the lower and the bronchial vesicle areas, then you're dealing with your asthma, COPD. And the last one, ignore what it says, it's a gurgle. We're never going to use raunchy again, are we? So it's a gurgle, and that is as denoted there. It's a real sick, mucus-filled sort of area, and you'll hear this bubbling effect. Okay, so as the air passes over, the fluid, the mucus, you'll get this bubbling sound that it can be quite characteristic. As you can see at the bottom, the wheeze is characteristic because it is continuous. The gurgling, if it's bad enough, can also be continuous, but when you're hearing the crackles to distinguish between a gurgle or a crackle, then a crackle is discontinuous. Okay, so it only happens where there's airways open and closed, whereas a gurgle is wherever the air is passing over, which is more often. So that's your summary, and we'll move on to an extension of the auscultation, if you will. So percussion is a thing that you can do for the chest. But as you're starting out in your career, and if you don't percuss a lot of the times, it can be very, very difficult to master and to hear the different sites of timpani that you can hear around dense versus airfield versus normal lungs. So it's quite difficult. Now, what we're really looking for is we're listening for consolidation. Okay, so if you have something with crackles or gurgles, you can listen for general consolidation over the whole chest, and you can also listen for the absence breath sounds for your pleural problems like pneumothoraces, that sort of thing. Now, to make it easier for yourself, you can actually place the stethoscope in the middle of the sternum and then percuss with your other hand around the area, listening for those density changes. Because as you percuss around the chest, the sound is going to travel through the chest, and if it hits some sort of consolidation, it's going to sound duller or different in a particular region of the lungs. So when you're starting out, you're not really familiar with percussion, but you still want to do it. Because auscultation, you just want to see if there's a region of the lung that's more affected because you can't quite figure it out with the auscultation, then you can place in an area and then percuss over those areas compared to an area that you know is clear and listen for those differences. Other things you can do, which are quite special tests, is really used to listen for signs of consolidation. That means general infection, so you've actually got mucus or water or something more dense in the lungs than airspace, or pleural effusion or a filling up of fluid in that pleural space. That's really what these tests are for. So bronchophony is listened to in those bronchial areas, so those mediastinal regions. You place the stethoscope over and you get the person to say 99. Now, if you say the word 99 and the lungs are filled with air, then you're obviously going to have a muffled, and you really can't pick it up. It doesn't really sound like 99. As opposed to abnormal, it actually sounds quite clear because it's vibrating off something solid. Water, more solid. I know it's a liquid, but it's more solid than air, so it sounds more clear. This is the same with egophony. This is done in a smaller area. So it's done in the areas that are around the vesicles, and you're listening for consolidation. This time you get the person to say E. If you hear E through air, it sounds like E. If you hear it through solid, with a little bit of a nasal quality to it, then it actually sounds like the person saying A. Now, if you're Victorian or South Australian, it's obvious that E's and A's get overlapped all the time, and it's very difficult to say the difference between an E and an A when you're using it in words, but in this case, you will actually hear the person say A, like a Queenslander, when they're actually trying to say E. Now, the last one is a good one to pick up pleural effusion as opposed to general consolidation, which your egophony is all about. Now, it's a ridiculous word called pectoral acute, and it's done by the patient whispering. So instead of saying 99, like your bronchophony, you actually just whisper 99. Now, if it is normal, you'll barely be able to hear it at all. But if it has that ability to vibrate off the fluid in the pleural space or even consolidation, it will actually sound louder and clearer. Okay, so there's special tests that you can do whilst you're doing the auscultation in order to easily pick up some indications of consolidation. Okay, so that brings us to the end of chest examination. I hope you found it interesting and enlightening of a way to conduct a proper chest examination. From here, practice it. Get yourself a good stethoscope, practice on people, listen to everybody's chest, regardless of complaint, because then you'll build up a database within your own mind of what normal sounds are and what difficulties you'll have listening to sounds from different people, different demographics, that sort of thing. Okay, but until next time, take care.